pretty significant mental health conditions. So with substance abuse mental health, we purchase services from contracted providers using state funds that we get from the legislature and the money that we get from the federal government. And we can purchase services for people who are enrolled in Medicaid. We can purchase services that Medicaid doesn't cover. So if a person is enrolled in Medicaid and they're in a managed care plan, and the managed care plan either doesn't provide a specific service or they deny the payment of that service, substance abuse mental health can use general revenue funds to purchase those services. And there are some services that we provide that Medicaid doesn't. We provide things like housing support, peer support, transportation, incidental funds to folks to help them address any barriers to treatment. Medicaid typically doesn't provide those types of services. So there are some things that we provide that they don't. So the service array that Medicaid funds and the service array that we fund through substance abuse mental health GR is very similar, but like I said, there are some minor differences. And local funds, like I said, are typically used for prevention services. So you may have counties that have taxing authorities, they have children's boards, and they provide prevention services for kids. So this is kind of the service array for adults, substance abuse, children's mental health, children's substance abuse. So in adult mental health, we've got the prevention services, we've got outpatient. Community support are things like peer services, housing, supportive employment, those types of things. We have FACT teams. FACT teams, if you all have heard of those, are very intensive community-based services for adults with significant mental health conditions. And it's a team of people that work together. They're accessible 24/7 to a person living in the community. And FACT teams often serve people either coming out of state treatment facilities or people who are being diverted, people who cycle through CSUs who are in crisis a lot. Sometimes are served by the FACT teams because it's very intensive community-based services. Then there are the residential inpatient services. The CSU, and it's kind of, it moves this way in terms of the level of intensity. So as you move this way towards A, it gets more intense. CSU, inpatient, and then state treatment facilities. In state treatment facilities, typically folks have to cycle through CSUs until they end up in a state treatment facility. So that's not the first stop for most people.
And that's those three places you talked about?
Yes, and those are for adults. Those are for adults. And there are other state treatment facilities that are run by private providers around the state, but we have three that the department runs. Adult substance abuse, same thing. We've got prevention, outpatient, community supports that are things like peer services, those types of things. Intensive outpatient treatment. Intensive outpatient residential detoxification, and then addiction receiving facilities is all over to the right. And then the children's mental health, there's prevention, outpatient, community support. Once again, it's the same thing. CAPT here in the middle, and some of you all may have heard of this. Those are called community action teams. The community action teams were funded by the Florida legislature about 3 years ago. And we continue to add more CAT teams around the state because the legislature has funded those. And it's a really cool program. It's a FACT team for kids. So it's a team of people who provide really intensive services to children in the community to either keep them out of residential treatment or to provide support to them once they come out.
So they go there in the day, but go home at night?
It's not a day treatment. They actually live in the home with their parents. They go to school. It's the whole thing. But there's a team of people that work with that family. They have incidental funds that they can use to address barriers to treatment. They can provide transportation. They've got a case manager. So there's a team of people. They've got a care coordinator. They have a therapist, and they have a team. So they have somebody who provides peer support to that young person. They can serve people ages 11 to 21, and then under the age of 11, given certain circumstances. So they have to have a identified behavioral health diagnosis, and then they have to have some risk factors, and most of them do. Their difficulty in school, they have some involvement with DJJ. There's some risk factors that go along with that, but it's pretty broad in terms of who would actually qualify for these services. And the reason why I'm talking about CAT so much, and there's another program that was also funded by the Florida legislature. It's called the Family Intensive Treatment Program. They're FIT teams. They funded those the last 3 years also, and they continue to fund more every single year. And the FIT teams are specific to parents with substance use disorders who are involved with the child welfare system. And the reason why our legislature funded FIT teams is because substance use disorders, parental substance use disorder is one of the most prevalent contributing factors to child abuse and neglect. And so there's more kids that are removed from their parents who have substance use disorders, and they stay in foster care longer. So the good thing about the FIT teams and the CAT teams is that the Florida legislature funded these with special appropriations with general revenue funds. They included the team approach. They included our ability to use incidental funds and peers. And they also focus on the entire family and not just a particular kid in the CAT teams or the parent in the FIT teams. It's family focused. So you look at the whole family. What are the services and supports that the whole family needs? And I think that this is a evolution for our legislature to acknowledge the fact that we need to look at family-focused services and treatment. So it's exciting. It really is.
What's the acronym again? CAT? What's CAT stand
It's
for?
Community Action Teams. And the other is Family Intensive Treatment, and that's specific to the child welfare involved.
So if you have a student, so for example, who had met the school, and the school basically had the child taken to do treatment, medication treatment, and the child was released, how can the child be able to have access to that community action?
Okay, so let me clarify. When you say the school hadn't taken the treatment, does that mean that they hadn't been corrected?
Yes.
Okay, just clarifying what we're talking about.
Yes, it wasn't his favorite acts.
Yeah. So the community action teams, the CAT teams, the department actually has the contracts directly with the CAT teams. Most of the other services that we have are funded and contracted through the managing entities that I just talked about a minute ago. The difference with the CAT teams is that the legislature specifically said that the department needs to contract directly with the providers when that first came out, and the providers have continued to want it to stay that way, to work directly with us. And so depending on where that kid lives, if a parent wants services, they can call the Substance Abuse Mental Health Program Office in that particular area. And if you want me to link you to a person, I can do that because we hold those contracts. And so you can find out where our CAT teams are and how you might be able to refer. But it's a really, really cool model. It's not like anything that we've ever had in Florida before. Because typically it's you have outpatient over here, and you have case management over here, and you have this over here, and you're not connected. But with the CAT teams and the FIT teams, it's a all-inclusive approach. It's a team of people that's working with the family that has a bunch of services that they can pull in to work with that family. And I think that it's a huge evolution for our legislature to fund something like that. We also have children's substance abuse services. There's prevention, outpatient, community support, intensive outpatient, residential detoxification, and then we have the juvenile addiction receiving facilities.
Can you go back up to one of the children's mental health therapeutic group on the residential, and then what? On the children's mental health?
CSU?
No, down on the children's.
Residential. CSU inpatient. So it's sort of the most restrictive, from the least restrictive to the most restrictive.
But what, yeah.
Crisis stabilization units. So the child gets Baker acted, and they're in crisis.
Okay.
And they go to a crisis, a crisis receiving facility.
Yeah.
That's what we're talking about. So it's short term. The purpose of the CSU is to stabilize a child who is literally in crisis. They're a danger to themselves, they're a danger to someone else. They go there short term, they stabilize them, they get them safe, and then what should happen is that CSU does discharge planning with that family and with the community to make sure that they've got services when they come out. And typically there's a whole federal and state laws around the Baker Act and how a kid can actually, how long they can stay, who makes that determination, is it more than 72 hours? Sometimes they don't stay very long. Sometimes it might be a day or two, sometimes it might be a week. It's a very short term kind of, that's the purpose of it. Residential is the much, this is the longer term, the residential part. This is sort of the continuum of residential placements for children's mental health. So this is the least restrictive, and there with these different levels, Medicaid pays for these, and also so do we, the general revenue funds. So therapeutic foster home, we pay for those with general revenue funds. Medicaid also pays for those, but Medicaid calls them specialized therapeutic foster homes. We call them foster homes, therapeutic foster homes, same thing. Therapeutic group homes, we fund those, and so does Medicaid. And then residential mental health treatment, we fund this with general revenue, and so does Medicaid. And when Medicaid funds it, it's called the statewide inpatient psychiatric program, or SIP.
Can you tell me about the difference between the two step downs?
Between which
Both, the difference between those two?
So therapeutic foster home, specialized therapeutic foster home, there's actually two levels. And the foster family is provided very specific training and support to have a child in their home with behavioral health needs. It's a foster home, but they have additional training on top of it and additional services for that particular child. And so there's a level 1, level 2. Therapeutic group home is, and actually in statute, therapeutic group homes are considered residential treatment level. It's a group home. There's intensive services and supports. Kids actually live there, and the length of stay is usually about a year. It's a little longer term. Kids go to school in the community, but they also have, and there's different models. They might have a mom and dad who live there, and they might have a therapist and a case manager and folks that come in, or they might have shift staff. It's different depending on how the group home works. So that's a therapeutic group home. And then residential mental health treatment, and then inpatient psychiatric is the most intensive. I wanted to talk a little bit about the population, or folks who have a co-occurring behavioral health condition, which could be substance abuse, mental health, or developmental disability, autism, Asperger's, because I've worked in this field for a very long time, and I think that this is challenging for the professionals to try to help folks, in part because we have two different agencies who primarily serve. Agency for Persons with Disabilities serves people with autism, Asperger's, developmental disabilities. Substance abuse and mental health serves people with autism and Asperger's also, and people with developmental disabilities, depending on if they can benefit from mental health services and if they have a mental health condition or substance abuse condition. So oftentimes, the providers who contract with the Agency for Persons with Disabilities, like behavior analysts and folks like that, are different providers than the folks that contract with substance abuse and mental health. You've got therapists, you've got psychiatrists, you've got case managers. So inherent in that is sort of a separation of the people that actually work in the field. Over the last probably 10 years, that's changing a little bit in Florida because we've required some of our mental health providers to have either a behavior analyst on staff or under contract. So there are folks who are board-certified behavior analysts who are also mental health professionals, which is really kind of cool because they have the expertise in both areas, but that's extremely rare. So I just wanted to to you all, but for some people, they're still catching up. Just a couple things that I wanted to say about that is that as a parent or somebody who may have a loved one or a professional who's kind of advocating for someone, one of the difficulties that we've really seen and that I've seen in working with folks who are newly diagnosed is that oftentimes what happens is because Agency for Persons with Disabilities and DCF Substance Abuse and Mental Health have their sort of funding streams and their eligibility and those kinds of things. Sometimes they don't coordinate well in terms of the planning. It's kind of like, well, we offer these services and we offer these services so you can pick, and that's really not how it should work. Best practice is that you start with a particular individual and you start with their family, and you figure out what it is that they need, what services and supports they need, and then the professionals and the agencies figure out how to pay for it. It's not the other way around. So I just wanted to make that point, so that you guys can advocate for that. Yes.
With the human things, a lot of it's something that we're looking on, on the spectrum, a lot of disabilities and communities. And, they grab it, it's not perfect, but then they go to places where they're talking about the drug rehab, or because the next thing that they're saying, like the drug, they're telling, kids or teenagers, and they're not anything like anything that's on the spectrum. And so it seems to me that they really get lost, like there's not a safe place for them to go, and if they're having violent behaviors, and parents can't deal with them, sometimes they have to call and help, depending on the society.
Absolutely. So that's why I wanted to, actually tomorrow, we have two focus groups. Dr. Steve Coleman from the Agency for Persons with Disabilities is going to do two kind of focus groups specific to this population to kind of talk about, what are some of the best practices and what are some of the issues, because it's always been a challenge for that reason. Because kids who have more behavioral issues, sometimes you're right, they end up in a CSU, and they're in there with other kids who have serious mental health issues. And really what they might need is more behavioral support, and the parents might need respite and peer support and something that they're not getting through the mental health system. And so that's why it's important to advocate for planning. You have to advocate for what you need. It's not like mental health, we have these placements over here, APD, we have these placements over here. It really starts with what the child needs. Yeah, that's right.
And they get their environment right. That needing attention. Right. They have
Well, if they have services in place and they're continuing to be Baker active and go through a CSU, and obviously the services that they have are not working. And so that's when the parents need to say, hey, what you have, what you've given me and what I have is not working. And so the CSU and the folks that are working with you are really responsible to help you figure out what else needs to be done and whether. So we have residential type placements for mental health, behavioral health conditions. Agency for Persons with Disabilities also has residential placements. The question is really what's the most appropriate for that particular child. These are some of the gaps in services and some of the challenges that we have. And I think I talked about this a little bit. There's gaps in local services. There's multiple agencies involved. There's problems with access and eligibility specific to just people who are really diagnosed, and flexible funding. I talked about that. Agencies have their own state and federal funding that come down, and it's very restrictive. And then limited understanding of people with mental illness, with behavioral health conditions, and developmental disabilities. There are, like I said, in the mental health, behavioral health world, the professionals that work with folks, their experience, their training, their expertise is really focused on mental health and substance abuse, where folks that work for the Agency for Persons with Disabilities, their experience, their training, and their focus is really on people with developmental disabilities, autism, and Asperger's about the DD piece, no, it's a kid. So you have to have either one person that kind of understands that whole child and how to help that family, or you have to have a team of people from the mental health world and from the DD world. So that's one of the biggest barriers, I think. And I said over the last 10 years or so, because we've started requiring some of our mental health, our SIP providers have to have a behavior analyst either on staff or under contract. There's some kind of blending that's happening with that a little bit. And it was amazing when we did that. The pushback came from both sides. The professionals that served folks with developmental disabilities and autism said, well, you can't have mental health people treat our folks. And it's like, wait a minute. You guys need to work together. So, we have behavior analysts and we have mental health folks, and because their approach is very different oftentimes, they have to learn how to play well together. And in a lot of states, they really don't. But I think in Florida, they're kind of starting to do that because we're starting to require them to work together. Yes?
My son is in a SIP placement for the second time, and they have ACDA on staff, and she's a part of his treatment team, and they all, I don't see any disagreement or non-continuation. She basically, because the reality is he's with techs and nurses who aren't behavior people. So when he's not with his therapist, the BCDA is the one like facilitating on the unit the positive behavior programs and the incentives, and I don't see, there's not any disconnection in his placement. Now, keeping the BCBA on staff is a whole other issue, but
when we changed, we worked with ACA because ACA is the one who pays for the Medicaid funded, the SIP services. When we changed the requirement for SIP services and the SIP providers to have a board certified behavior analyst on staff or under contract, this was probably 8-9 years ago. So they've had a little time to get used to each other and sort of figure out how to work together. But when we first did it, typically they didn't work together. They worked in silos. And so they've had a little time to kind of figure out how to make it work. So it sounds like it's working, so that's good.
well, I just think that they see the benefit to it. I mean, all the kids, because the BCBA is going to use like positive behavior stuff, like teamwork and all the small therapeutic things, while the therapist is working with the child individually, which is great, and so is the BCBA, but she also works with the unit as a whole.
Right, exactly.
In the implementation of incentive programs.
And
so they all want to help the other one get out.
And part of the reason why we include behavior analysts in the SIP services and SIP programs is to reduce the need, actually, hopefully, to eliminate the need for seclusion and restraint. Because behavior analysts understand positive behavior support, they understand behavior change, they know how to write individualized behavior plans, how to change behavior, whereas sometimes therapists are more focused on the mental health treatment. And less on the behavior. So when you have a team of people that are covering all of that, that's the best way to do it. I'm going to hurry up because I want to have the opportunity at the end to kind of have some discussions, and I don't want to hold you guys up. But here's some best practices for folks who are dually diagnosed. Families and individuals should be essential and drive the system's decisions. So basically it's what do I need and how do you get it done. Person-centered planning is what does a person need, and then you figure out who pays for it. So you basically start with the person. Services and supports, they're based on the assessed needs, not on the diagnosis or funding. That's up to the agencies and the professionals. It's their job to figure that out. Agency collaboration, rather than reacting, there's silos or bleeding. Sometimes that occurs, especially when state agencies have really limited funding and they're trying to protect it so that they can serve the people that they serve. Sometimes there's a bit of that. Services are provided in a least restrictive and normal environment, including school settings, at home, in the community, and services are developmentally and culturally appropriate to the family and the person being served. Questions, discussions, comments? That was just a very high-level kind of overview of how the behavioral health system is structured. Because I don't work for ACA, I can't really talk about what they do and what they don't do, although I have enough knowledge of them to make me dangerous with their Medicaid, their managed care plans. But I think I gave you guys a couple of really good resources on their website, where you can kind of find out about the MMA plans and what they cover, and also the TCF and our managing entities. So questions, comments from anyone? No? Is this surprising? Did you all learn anything? Is it still sort of a mystery in terms of who does what?
Yes.
It is to people who actually even work in the system, so don't feel so bad about that. But the purpose of this is so that you all can have a basic understanding of the landscape so that you can advocate for yourself and you can navigate it a bit.
When I walked in very late, and I apologize, I'm trying to do a couple of things at the same time. But you were mentioning that APD has some, was it APD that you were mentioning that has some like trained personnel? For the children to receive services though from APD, they would have to already be on the wait or off the wait list?
No. I'll just say, like, so for us, my child has been Baker acted several times. We have Medicaid, so he goes to, he gets med management somewhere and case management somewhere, and then he also has an autism diagnosis, so I do get ABA therapy / counseling, and then there's like that huge gap between why your kid's getting outpatient counseling maybe every 2 to 3 weeks, but that's when they have an appointment, and then they're being Baker acted, and then it's like, yeah. So he's on his residential placement. Now we started to go to that. When she this is where I was going to comment too, that there's a map like in here. So after being Baker acted so many times, and okay, you need to just stop Baker. He can't just Baker act, come home, Baker act, come home. Was when I was finally referred to Lutheran Services. Okay. So my comment was just going to be that I'm sad that it took so long. Well, my kid's only 11, so for me it did take so long, but I'm sad that it took so much for me to finally get referred to Lutheran Services. Now, my life after Lutherans, he is on the wait list, and he has gone up on the wait list since he's been in residential. But Lutheran Services, the way it was explained to me was, here's the ones that Medicaid pays for. Go to them. Let's send your packet there. I mean, it was a team decision. Like, we went as parents, we looked at them, we toured. Again, it's hard. My kid has autism and he's bipolar. And if you just can't come, like if you send out his packet asking for them to take him and literally everyone says no, then you can go to some of the med waiver places and look. But they wanted me to exhaust the 12 Medicaid options first. And I'm kind of picky, and I didn't need to exhaust them. There's actually a few that are pretty good.
And there are some residential treatment centers, just so that, because your son is receiving SIP services, so you understand all of this, but there are 10 residential treatment centers around the state who Medicaid pays for residential treatment services, and those are called SIP services. We also, the department also can pay for residential treatment services using state revenue dollars, and we contract with those same providers. So you have providers who may serve kids who are not Medicaid eligible as well as kids who are. So they kind of serve both.
But I am having a conflict with the fact that I want him to go to an approved APD med waiver group home. I don't particularly love my group home options for Medicaid. I prefer my med waiver group home.
If you want to hang out a little bit afterwards, we can talk about the CAT teams. Because the CAT teams, I talked about those a little bit. Those are the most intensive community-based services that we have for kids. And a lot of kids who are coming out of residential or parents who would prefer not to have to put their kids in residential are being served by the CAT teams. So we can talk about that. And I can link you to somebody and see if we've actually got one where you live. And hopefully we can keep hitting the legislature up for money and we can have a CAT team in every local area. So far, they've continued to fund. Any other questions, comments? So we were talking about the statewide inpatient psychiatric program, and those are residential treatment services that are funded by Medicaid, and they just call them SIP services.
So it's like a Baker. So sometimes when your kid gets Baker acted, like I don't know where you live, but sometimes you go to this. All right, so I don't know how your crisis service teams are, but like some of our hospitals are there's crisis kids on one side, and then there's long-term kids on the other side. The kids on the other side, or in the other building, are there, like, the residential kids, they live there longer. So, and then for me, we just looked at, some use their own private schooling, some use contracted services through the public school system. Some use, it just depends, like.
Where your son went, did they understand the autism?
Yeah, well, I picked a place, we drive far. My son's in Bradenton at Manatee at Palm Shores, and he is in a unit with only 6 to 12-year-olds, which is amazing because a typical 6-year-old also doesn't wipe their bottom appropriately or take a shower appropriately. So it's okay that my 11-year-old lacks some severe social skills because a 6-year-old little boy and a 7-year-old little boy do too, so it kind of worked. My son is cognitively average, but socially impaired and self-help impaired. Like, he's just, like how it goes. But he's bipolar, and so I just went to the places. I went to some places where there was, kids were mixed up to 17, and I was like, no way in the world. My kid's a filter, in the ear, out the mouth, and he has no idea what he's saying. But now he's with 6 to 12-year-olds, and he's 11, so it kind of worked. For my kid, it worked. He's with younger kids.
I'm really, really glad to hear that you actually went to and interviewed the residential treatment centers.
Oh, that was our third one.
Right. So there are some who, the Medicaid funded SIP services, those providers are required to have a behavior analyst on staff or under contract.
Yeah, we know.
And so they have a much better understanding of how to provide treatment to kids with autism and Asperger's, because they have the expertise there. Not all residential treatment centers do that. Some of their behavior programs, some are more sophisticated than others. So when I've worked with parents and worked with family members who have been seeking services, that's one of the first things I say is that you have the right to interview them. So you ask them questions about what is your ability to treat my child? What is the expertise with, serving kids with autism? Those are the things that you as a parent and a family member have the right to do, and then you can pick, especially with Medicaid funded services and also with general revenue, but with Medicaid as well. The parent or the guardian has the right to place their child in any residential treatment center that's funded by Medicaid. So there are 10 SIP providers, and you can interview all of them, and you can say, I like the one in Pensacola. That's where I want my kid to go.
And that's
So
what we
you have a right of
did.
choice.
We fill out a packet, the same packet. That way you don't have to do paperwork for everybody, because you fill out a main packet, and then we just kind of looked at them and then submitted the packet. Some are on a really long wait list, and some keep boys separate from girls, and some use public school, and some use their own private school, and some don't even take a kid with an autism diagnosis. Anyway, some tell you, some are mixed with really older kids.
I can talk to them. Any other questions, comments? I hope this was helpful, at least to provide kind of an overview of how things work and who does what. If you have any questions or you want to talk about any particular individual or family member, just hang out and I'll hang out too and we can talk about it. Thank you guys. Enjoy the conference. This is awesome. It's just wonderful to see so many people here. It's wonderful.